Hi, Praveen.
सेव कर लिया
ठीक है हाँ इसे बियॉन्ड डायगोनली जाना हेलो हेलो हाउ आर यू
Praveen, Brian is here
Hi, good afternoon.
from
कैन यू
Delhi.
हियर एंड सी
From Delhi
या
to.
हाउ आर यू
I'm very well.
Yeah.
From your lab to Hyderabad
दिल्ली टू मुंबई
via Mumbai.
दैट्स राइट हाउ आर थिंग्स
Things are
कैन यू
good.
हियर अस
Yeah, we can hear you very well. We can see you.
Okay.
We
Maybe
can
you could
So we
just
were
start with
yeah we
case
were
Just
waiting
tell
for a
us.
long time
Yeah, I'm so sorry because we didn't.
Yeah.
We didn't
So-
realize. Sorry.
so we were thinking that we have to finish the case
No.
because
Then you can
it
take
was
your.
too long
Then
yeah
you can
anyway
take one more
so
case
let me
after
just
that. You all are so.
yeah it's already ready in the other one the one Tavi is ready.
Oh, you're showing a Tavi? Okay, very good.
So, no, I'm not showing Tavi, only coronary today. So, Dr. Neeraj is here, Neeraj
Yeah.
Gupta. So, he is going to quickly tell you about this
Okay,
case.
done.
And then we'll go forward. Angel. Huh.
हेलो गुड आफ्टरनून एवरीवन सो हियर इज अ केस ऑफ 66-year-old gentleman who is a hypertensive diabetic smoker and he had ACS on 25th around 5 days back and his drops were
Sorry, we
elevated.
don't
His
see
ejection fraction
slides.
was
Can we see slides?
around 35-40%
No, so Angel laga do. Angel.
on echo
Okay.
and we did the angiography and you
So,
see there is a plaquing in the proximal left main and the distal left main is there is plaque and from the LAD it's 100%
Thrombus containing.
occluded. It's a thrombus containing calcified lesion and which is filling retrogradely also. You can see in different shots. And next shot,
next shot, please. Circ is okay.
The circ is okay. Left main distal is disease around 30-40%, and there's insignificant blockages in the circ and the ramus. So next shot, please.
Next.
So here we can see there is a plaque in the distal left main also around
Next.
30% or so. Next shot, please.
Next. So you can very well see that it is a combination of thrombus plus fibrocalcific lesion here in this patient with acute coronary syndrome, and also there is a plaque in the distal left main. Yeah. So we will see now what we did. So first shot, please. Come to the first shot. First shot. Fluoro. Okay, first shot. So we took the guiding catheter. This is a 7 French guiding catheter. And we took this first shot. Next, please. And we still don't see the LAD here. So we started wiring with the Fielder XT wire. Next slide, please.
May I just ask you why you
Fielder
don't
XT wire,
have
we wired it.
contralateral injection, which is standard in
No,
such-
so I will, yeah. No, it is okay. We don't need contralateral here because in CTOs we generally do contralateral, but in the recent occlusions mostly we are able to, and we saw that this LED is filling retrogradely up to that point. So we thought that it may be absolutely easy because we will take a Fielder XT wire. So we took a Fielder XT wire which went into the first diagonal. So we thought let us put some daughtering effect with the balloon. Next slide, please, so that we can then enter into the main LAD. Next slide. Next. Okay, so this is the balloon which we are using. It's a 2 mm balloon. Next slide, please. So then we did the IVUS. We can see the IVUS now. Show the IVUS pictures to assess the distal part of this vessel and going into the proximal part. Show the IVUS, please. Yeah, okay.
Just focus on the IVUS.
And next, fluoro image, change. Fluoro image. Okay, next. So then we realized that, yes, we can now see the LED very well. We changed with the BMW wire because we generally want to finish the procedure with the, a BMW wire rather than finishing it on a Fielder XT because it is still, a very wire which can create problems if it is going too deep inside. Next, please. So we were able to put this wire into the LAD. This is a BMW. And then we were checking the ostium of the circumflex because in case, and we probably have to put the stent from the left main, distal left main into the LAD. So we'll just wire the circumflex also. Next slide. Next. Yeah, so this is the wire in the circumflex, and you can see that there is a large chunk of thrombus mixed with calcium. So here, what are the choices? So now this is where we are right now, and Dr. Pinto, please go
Yeah.
ahead. If you want to quickly discuss something.
Yeah.
Yes,
so
yes.
so we we saw your IVUS, we saw your fibrous tissue out over there. You wired the circumflex, and we have Dr. Franz with us. So I think he may have a point or two to make. So
So if I understood you right, the LAD in mid part of LAD, this is a chronic total occlusion, right?
so
No. There is no
it-
chronic total occlusion.
No,
Yeah.
it's not a chronic total occlusion.
It's acute.
It's an
It's a acute coronary
It's an acute.
syndrome.
Yeah, it's an ACS, doctor.
Okay.
The
sorry, I
patient came
didn't-
with
I
acute
didn't
coronary
follow you.
syndrome, ACS.
It's an ACS.
Okay, that's fine.
So you have now got a BMW wire down. You have exchanged it. You have
Yes, the BMW. Yes, so now you see the fluoro. We have
Yeah.
the BMW in the LAD. We have the BMW in the circumflex
Yes.
as a protection wire.
Yeah.
And the plan is to take a laser. So we have taken a laser to treat both the thrombus and the fibrocalcific spots in this LAD. And we have particularly not taken root ablation here because, with this much of thrombus, I don't
Yeah,
think it
but
would be a great idea.
how does laser
for
work
this
in
kind of situation,
Yes. So in calcium, doctor.
no, yeah,
No, it doesn't work so well in calcium. No.
yeah.
Yeah.
No, so it doesn't work so well in calcium, but the fibrotic portions actually get, broken with the laser. So we will use the laser now. I'm taking the laser, so you will see how easily it will go. So, okay. So we have taken, what is the, okay, so I'm starting the laser with 45, 25. 45 is the fluence and 25 is the rate. Ready, be ready. So now we have to make the machine ready, and you can see the sound. You can hear the sound,
Yeah.
and the catheter moving deep inside, slowly, 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 slowly. Okay,
doesn't-
finish.
Dr. Praveen.
And now again, so it will
Doctor-
again become ready.
Yeah.
Yeah.
Dr. Praveen Chandra, do you
Yeah,
inject saline at the same time as you are going with the laser, or do you inject it
No,
later?
not necessary. We inject saline before, and then in between also we keep injecting saline. Now you can inject saline. So that was a good point you made. So that we will now inject more saline at this stage. So there should be no contrast.
Yeah, but
There, that's okay.
we were
So
seeing
I will-
another operator do this some time back. He was injecting saline at the same time as he was lasing. Is that also a technology that is preferred, or you can
Yeah,
do
you
it
can
either
you
way?
can do that, but it's not necessary.
It's not necessary.
Yeah, not necessary. So I'll make some runs, more runs, and the catheter is not going into the distal part, so I'll probably increase the rate. So to increase the penetration, we will increase the rate. So increase the rate, it was 25, now we will make it 40, 45, 45.
Another
45.
question to
You saw
you:
that?
Do you believe there is a huge chance to provoke embolization of some debris and thrombus to the distal LAD?
I mean, yeah, so whenever we do any intervention in a thrombotic lesion, always there is a chance. But with this laser, the chance of embolization will be lesser, hopefully, because the thing is that, it actually vaporizes the thrombotic burden. So,
Do you approach
see
this
that
based on
this is a
study
spot.
data? May I ask you, because we don't use this approach for acute coronary syndromes in Germany.
Yeah.
So you
So what approach do you
based
use?
on
You tell
data
us.
or your own
Okay.
experiences?
So increase the fluence. Yeah. So basically, we have this data showing that it works in thrombotic lesions. So now I've increased the fluence also. So we'll increase the fluence to 60 and the rate to 60. Okay. So I'm making these multiple runs, and you see the sound changes.
Yes, as you increase the fluence and you increase the power, your sound is definitely different.
Yeah. So we will do some more runs because at one point it is still having a difficulty.
Okay, now one more question. So from your perspective, the chance to get less slow flow or no flow is smaller if you use laser compared to standard angioplasty, balloon angioplasty?
Yes, yes.
So you
Yes,
have less chance to
The
create
chance
slow
should be
flow.
lesser.
Okay.
Yes. So you can see that at one point
Is it having
the calcium
difficulty
was
because
quite
of
heavy.
Is it
and
having
that-
difficulty because
yeah,
of the
some-
calcium?
Yeah, because of the ring calcium at one point, and as I said, now it has crossed. You see, it has crossed.
It did cross.
Yeah, it has crossed. Yes, yes. So you can see that it takes some time. So you have to make multiple passes, and then it works.
It's necessary to take a look between if you have flow or slow flow, because you didn't check now your
Yeah, we can
flow.
do that. I will do that. I will do that now. We can take a shot and take
Oh, will be
yeah.
great.
Yeah. The ECG looks good, and the pressures are okay, so hopefully everything is fine.
Let me first.
So Dr. Neeraj is going to take a small coronary shoot. Okay. You see that there is no big slow flow at all, but certainly still we see large amount of thrombus is already gone, just with this, you see? So we will do some more passes because there are some 2 or 3 more
Yes, there is some,
thrombotic
but the ring is difficult.
areas.
So,
Yeah.
what is your pharmacological
So I will do some more.
treatment behind? So the patient
The
is
pharmacological
pre-treated
treatment
with
is-
prasugrel and aspirin, and
Yes, yes.
would you
Yes,
see the
yes.
chance
And also we have
now
given
to
heparin.
improve?
10,000?
We have 10,000 heparin, ACT is 290.
So now I will do some more. So you will see the effect of this laser on the thrombus and see that there will be less chance of slow flow. So we will go a little slow.
So from your point of experience, how many runs can you perform and how many runs are useful and safe?
I think, we have done up to 10,000 impulses. And in this case, how many impulses have we done?
Move slowly, slowly.
It's 5526. So we have enough, up to 10,000 I have seen that, there is no major issues. And we can even go higher sometime. So,
What is
and
standard?
I have done this in vein grafts also, it works very well. For degenerated vein grafts, also it works very well in thrombotic degenerated vein grafts. So this will be my last run.
It must be 7,000 impulses.
We have done about 7,325 impulses. You see?
Okay, it will be
Okay, let's
great
take a
again
shot
if you
again.
make injection to see what's happened after multiple
We will do
runs.
that. You see that the thrombus is, gradually very little thrombus is remaining. The artery is.
I have impression
go-
you
there
have
is
now
some
even
little
in
slow
left
flow at
main
this
more
stage, but-
thrombus. Patients is stable.
No, there is no thrombus in the left main.
Look
In
at
fact,
in
the left
distal
main is
LAD,
looking much
you
cleaner
have
now.
TIMI's
Yeah, yeah,
0,
yeah.
maybe max 1, and now you have a bit more
Yeah,
haziness in distal left main,
yeah,
much
nitro.
more than
We'll give
before.
some nitro because we were in the artery for a long time. So now we will give some nitroglycerin and maybe diltiazem or nicorandil and see how it looks. Okay? Go, show me.
And
And now I
so
will do some gentle dilatations using a angiosculpt. Give me angiosculpt,
You want a 3 millimeter?
3 millimeter.
So what you see, it's a time to take balloon and to make prodilatation and to give some
Yes,
2B3A inhibitors because that's really a lot of thrombus mass.
2B3, we will see. Yeah, we will see if we require, we will certainly give it. There is no problem. And I am taking an angiosculpt 3 into 10. And then we will go do some gentle dilatations using this balloon because this will have better plaque modification and effect. Looking at this lesion which is calcific plus thrombotic. So this is not a very great combination, but nevertheless we'll have to treat it. Yeah, okay. So it is going without much difficulty and
It's there.
okay, and it went off very nicely. Check please. Check please, I'll cause a little bit. Okay, that's lovely, lovely. Go up.
There is some
1, 2, 3,
maybe little perforation. Take care.
5. Yeah, don't worry. Yeah, we will see. 6, 7, 8. Deflate.
5 minutes, 3, 4 minutes.
Deflate.
This is a maybe
So I've done
indication
some
for shockwave
dilatation here. I'll
balloon.
pull back a little bit. Yeah, in case we require, we can use it. But I'm using this. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay. So it has expanded well. As you can see now, at the second time, deflate. So, go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So balloon is well expanded. So I don't think we will require the shock wave. Deflate. Deflate. Because with these, very small spots of calcification, generally I think we are able to avoid the use of shock wave. Go up. 1, 2, 3, 4, 5, 6.
I think you have to take
7, 8.
smaller balloon and maybe 2.020 and
Yeah,
go
10,
to
12.
behind the bifurcation because from my point of view you have a huge embolization in the distal part of LAD, so
Check,
it's not beneficial.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
I think very important point
Well.
to rescue this patient is to have a
Deflate.
second wire in LCX because that's already done, but it's
1,
I
2, 3,
think
4,
crucial point
5,
to
6, 7,
protect
8.
LCX.
10, 12, 14.
And
9,
they
10,
probably have to now
12,
start to prodilate
14,
the left main, which initially was not
deflate.
critical, not subtotal. In case if they have
Okay.
embolization to the LCX.
So now you will see, we will take a shoot nitrogen.
How is patients according the pressure, blood pressure? It's fine?
Yeah, everything. Show the hemodynamics. Show the hemodynamics. ECG is okay. The pressures are okay. He's in good
perfect.
situation. All is fine. Yeah. So we are in good position. Show me. Okay. All right. Now we can do a IVUS. Give me IVUS. We'll do IVUS now. So we'll try to, generally, we'll give it some time now for the artery to breathe a little bit and then do a IVUS in between to see how it looks, and then finally we will take a stent. So we have planned to do a LAD from the left main, most likely. Wire is very deep inside. Okay. Okay. All right. Okay. Show us the distal area. Can you?
Can you go deeper with the IVUS behind the bifurcation?
I'm trying. Yeah. This is the. Yeah. Okay. So this is the vessel beyond the bifurcation, and
This is at the.
this is the bifurcation, and you see that there is a calcification here. Yeah, but
Yes,
it has been
nearly
broken a little bit. The calcium
270
ring has been
degree.
broken.
Probably you have to
Yeah,
use
so
here
this is
shockwave.
a calcification which has been broken.
Shockwave
I
on
will
top.
see if I am able to dilate with the same balloon, which is the angiosculpt. I will go with that, because if the calcium can be broken with that, it's okay.
Give me that balloon.
Now, sure. Give me the balloon, please. There is some spasm actually. There is downstairs, there is a spasm and a dissection. Kya hua?
So this is now current situation. So there is a quite large diagonal branch. I think you should also try to protect. But first of all, you need as well as longer stent now.
Yeah, I'll need a stent actually. I think we can.
Negative.
Another case. Okay, maybe between we just skip to another cath lab,
Go
and you can work now.
2468.
So we can see how our colleagues approach the LAD. So we see now long stent in LAD from left main, or there was
Go
no
up.
pot.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate.
Down. नहीं मुझे लगता है
Balloon jump a bit
इसकी
back.
पोजीशन करो आरे क्वार्टर में आया फटाफट
Ariocaudal.
Patient is
Okay,
stable, as
so are
we can
you
see.
people back or what?
So we are back in your cath lab. So maybe you could summarize. So after we saw this huge dissection,
Yes,
you
yes.
started
Yeah.
to stent LAD from
Go
left
up.
main.
1, 2, 3, 4, 5, 6, 7, 8, 9. Deflate. I think we'll take a 4 for that one.
4 लेना 3.5 देखो
4. Yes, maybe it's 3.5, whatever.
3.5 का balloon.
Okay, check now. इसको निकाल लेते हैं. So what we have done is, we have put a stent which is 3 into 40, taking into consideration that this stent should be expandable to 4.5. So there are not many stents which will go from 3 to 4.5 in the left main. So we have taken this stent which is going to 4.5, and now I will take a quick check how it looks. This looks all right.
So which
And
stent did you
distally,
take,
the
Praveen?
vessel is in spasm. So this is a cruise. I think it's a cruise. It's a cruise. 340 cruise. So there are 3 stents which can go, a 3 millimeter can go to 4.5 or above, and that is cruise, biometrics, and angiolite. We have a chart here. Maybe you can see the chart.
So
We have put up a chart.
you said
which
cruise,
stents can go.
you said
Epicranial.
biometrics.
Cruise, biometrics, and
Angiolite.
angiolite. So they go from 3 to 4.5 according to their specifications. The Zines goes, the 3 goes to 3.75 maximum expansion, and the 3.45 goes to 4.5. Okay. So we always have this chart ready in our lab so that we can make quickly, you don't have to remember.
This is 3.5 million.
Oh, okay. So I am doing some dilatations now. Epicranial, please. So we have dilated proximally with a 4.5 and
I think the most important point is patient is
go up.
stable at the
1,
moment.
2, 3, 4, 5, 6, 7, 8, 9. Deflate. So I am doing dilatations with the 3.5 in the LED, which is above the diagonal. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 12. It is expanding very well. Deflate. So there is no problem here. And go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 12, 14, expanding very well. Okay, deflate. Okay.
So it will be interesting now to make an
And,
angio in this projection to see how
12,
is the
14,
flow in
16,
diagonal
16,
branch.
16, 16, yeah, deflate. So the proximal part of the LED has been expanded and treated completely to, as far as we had planned, and now we will see how it looks, okay? So we will take a look
This is nitrogen you want?
because, nitroglycerin.
Or distal
I'll give some
spasm?
nitroglycerin because the spasm in the distal vessel is there. And now we will see. Diagonal is flowing well. So there is a distal dissection which I have to treat.
Yeah,
with
you have to fix dissection
another
and
stent.
don't forget
Yeah, I think we'll do that.
to
Give me
keep
another
this
stent.
diagonal branch
Give me
open.
another stent. Yeah. Yeah. The diagonal is okay. So we are beyond the diagonal branch. The stent is there. Show me this. I think 16 should be okay. 16. Give me a 16. Okay. So, huh?
So you have
It
to
will take at least 2.5.
to fix LED now as next step.
Yeah, I'm going to do that now.
You mean the smallest thing? Yeah.
So we went with the high pressures with the angiosculpt at to dilate this lesion, which worked out quite well. And now we are going to fix it. Another stent. Okay. So this is the second stent. I'm taking it inside. No problems. Okay. And we'll check in the...
So you will have some minimal overlap probably.
You can push.
Yeah, minimal overlap. Yeah.
So would you like to
So I
use
can
now
see on the-
stand boost?
Yeah, it's already on. I don't think you are able to see that. We have a system with the IVUS. This is the Volcano system, where I can see it with the fluoro online, the stent boost, which is on the side. So at least, if can somebody show this?
Can you focus on this one?
It is a very nice thing because I don't have to do cine imaging during this time. Go up. 1, 2, 3, 4, 5, 6, 7, 8. So we can see it very clearly. Deflate. 8, 8, 8. Keep it at 8. 8, 9, 10. Deflate. Okay, so can they see this? This screen. So this is the IVUS co-registration image, the screen, which we have, and it also gives us the this one, the stent boost. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 12.
14.
Deflate. Okay, nice.
So do you believe not to protect
So
the
now
side
we will see.
branch, not to protect diagonal branch? It
No,
was
we were
okay?
already beyond. The stent was already beyond the side branch, and this was in the distal part. The dissection was in the distal part, okay? So now you can see that the dissection is gone, and we can give some more nitro, please, because the spasm is still there, that's all. And we see that many times in these vessels, that they just take some time to.
Yeah, what we see, there is still
out
some
of
flow
the
in diagonal
spasmodic.
branch in case you could go here with...
Yeah, the flow in the diagonal is very
key
good
sync
actually. There is no problem. You see that. It is perfect flow in the diagonal, and it is a nice flow now in the LAD. Okay? You see that?
Yes, we
Okay,
see.
now we'll do a
But
RO
I'm
portal.
still concerned according the stent area in distal left main. So we have impression it's not really well opposed and 1.5 millimeter
So I'm
too
going
small.
to do an IVUS for that.
This is definitely too small.
So we have gone with
stent.
so you can see the proximal edge is 4.5 already. So I might do a IVUS, no IVUS, this is the, so I can do an IVUS to see how much is the, expansion and, whether we need to do more. But overall you can see all the branches are flowing nicely. There is no slow flow at this stage. And we are okay. And the patient is absolutely stable, there is no problem.
No ECG changes, nothing.
No ECG changes, nothing.
He's maybe around the curve of the distal left one now.
So I'm just release it. So I prefer using this IVUS, although it is 20 megahertz, but it is quite fast actually, so that we don't spend that much time on maneuvering this.
Probably you need post-dilatation with NC balloon.
Just focus
We
on
will
IVUS.
see, we will see.
IVUS.
I have done with the NC balloon dilatation with a 3.5 in the proc. So you see, this is the distal segment. Can you see the IVUS? Okay.
Yeah.
This is the distal edge of the stent.
Yes.
Reasonably well expanded here. Yeah, 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 yeah. Okay, overall looks good. And nothing much really. And now, here we have to expand, okay?
Yeah, this is
Yeah,
definitely...
so this is the distal left main and bifurcation. So I'll take and the proximal edge is well deployed. You can see, proximal edge is perfect. So I'll take the 4 millimeter balloon maybe to go to very high pressures.
Can you show us
NC
again the
balloon.
distal left
Overall,
main?
the stent looks good. Yeah, please show. Let the whole thing run. Let the whole thing. Pura chalne do. Give me a balloon, 4 millimeter. So this is the distal edge of the stent. Hey, show the IVUS. Show the IVUS.
Distal edge.
Show the IVUS. No.
Fast.
Last shot, दिखाओ. Last shot. Show the last shot. That's nice. So I'll take this wire out also because everything looks all right. Okay. इसको पकड़ लो. Take this wire.
Yeah.
So I think this is going to be the final dilatation of the proximal ostial LAD and the distal left main. Okay.
So you are happy with the distal edge of the stent?
Yeah, distal edge looks reasonable. We can just do some more dilatation. That's all. Otherwise, there is no
It
dissection.
looks like 2 millimeters on the IVUS.
Go up. Go up. 2, 4, 6, 8, 10, 12. 10, 12, 14, 16, 18. One take. Okay, deflate. So we have gone to high pressures on this. Okay, that's lovely.
Sir, what was the size of this balloon?
This is a 4 into 12
Okay.
NC.
Okay, sir. Thank you.
4 into 12. So earlier we used a 4.5 for the proximal edge.
So it looks like
There is a chunk there, but we have good lumen, it appears, at this place. And okay, go to epicranial.
So what do you plan to do with LCX, with CIRC?
Right now, I mean, we have to do nothing for the LCX because the flow is good and there is no major issue in the LCX at all. So now you can see that the flow is good in the LAD and the diagonal. So to me, I think everything is looking all right. And
So what we see
for the
from
distal
here,
edge of the stent, somebody.
we see some haziness in distal left main and
No, there is no haze. It's absolutely clean. There is this calcium which is looking like a haze. It's a calcium which is up there.
Yeah, maybe you're
Nothing
right.
else. The lumen looks very good. Show me with the IVUS. We can do the IVUS.
So the diagonal branch is open.
If the lumen is good.
We have flow in CIRC and the intermediate
yes.
branch.
Every branch is flowing. There is no thrombus migration anywhere.
So I think for now, so you have done the case. The only question will be to
Yes,
take
more or
8 or
less.
6 millimeters NC balloon for distal left main, to make even better
IVUS.
pot maneuver.
IVUS. So I have done this.
And there is
okay,
no
now you
clear
see
data.
the lumen of the.
There was no clear data regarding
how big
kissing
it
or
is?
not
So
kissing
this
for
distal
CIRC.
lumen is now, look at this. This distal left main is looking very rounded, nice, fully dilated. Okay,
Yeah.
you see, it's quite good actually.
Where's
And
CIRC? Can you see
into the
the
LED
ostium
also
of
it
the
looks
LCX?
reasonable. Yeah, you can see. I'll just show you. Okay, here it was.
Would be great if you could show
Actually, there
us
is a-
the LCX ostium.
Yeah. Yeah, you can see now. Yeah,
This is the
yeah,
ostial LED.
yeah,
Distal left main.
yeah. So the ostium of the circumflex, we can't make out very clearly, but it
Oval
looks
shape,
okay.
that's why
Yeah,
we
it's
done,
a,
but check the area out here.
check the area. How much is the area? And you want to see, I can take a final shot now into the RO epicaudal position to see, look at the ostium of the circumflex. Center, please. Center. Center.
Yeah, there is some
So this
discrepancy between
looks-
left main and stand area. So
Yes,
from
there is
for
some,
me,
because of the nodule.
I think you should take a
yeah,
short
tell me,
6
yeah.
millimeter or maybe 8 millimeter short 4.5.
Yeah, we can take
stand.
let's take a NC. But it is actually a nodule. It's a big nodule there.
This is very acceptable result already because you open
Yeah,
LAD
it's quite
and
acceptable actually.
treat left main. Result is acceptable. You have TIMI free flow.
Yes.
However, I think according the long-term safety and survival, probably will be better if you perform final pot with larger, shorter balloon.
I'm doing it.
So he's
Based on your
you're going to do with the
recommendation,
4.56, Praveen?
No, I have taken a 4 for right now.
4
And
by?
then we also have a 4.5. We will see. Okay, go up. 2, 4, 6, 8, 10, 12, 14, 16. You see how well it is expanded now? 18, 20. Deflate. Okay, so with this, hopefully we are done. Come to the epicranial.
Area is 8.8.
8.8. The area at that spot is 8.8 on IVUS, which is quite good actually. I think we are okay. We should not do too much because sometimes, you know, as everybody says, and you also say, that the enemy of good is what we are trying to do. Okay? So for me, it's okay.
I think so, Praveen. I
We
think,
can do that with the
you know, the only thing is that
Okay.
there was a nodule over there, so I don't think we can do anything more to that calcified nodule.
yes.
So I think
And
you
even
did an
shockwave
excellent,
will not be able to treat it.
yeah,
I can
excellent case.
tell you. Yeah.
Thank you very
So
much.
thank you for
Thank you.
really live
Thank you.
demonstration how to
you.
open
Thank
the LED with laser. And it was
you.
difficult case. Thank you. Well done.
Thank you.
Thank you.